So we are the three EBPs in a pod. I'm Kaylee.
I'm Nicole. I'm Shelby.
And we're going to take you on our evidence-based practice journey today entitled Comparing Peas and Carrots, Choosing Treatment Methods for ASD. But before we get into that, I want to draw your attention to the small pieces of paper you have in front of you, as well as this lovely green board that Nicole has. This is a visual schedule, which is a tool used in autism treatments, especially in one that we're going to be discussing in this presentation. And it is used to help keep children with autism well regulated within their environment and to teach them some predictability throughout their daily schedule. So we thought we would make one for all of you so that you all stay happy and well regulated throughout our presentation. And so we stay well regulated as well. So Nicole's going to go into how to use that here in a few moments.
Okay, so as you can see, there are pictures on your visual schedule. These pictures will match pictures that are on our slides. There is not one for every slide, but when we get to one of the slides on the schedule, I will bring that to your attention so you can cross it off on your schedule as I put a P on our schedule as well. So now Shelby will talk about our EDP process.
Okay, so this staircase represents the process that we went through to get to this point to present to you guys today. So it all started with selecting a case study. Back in the summer, we were given a list of case studies and told to choose the one that seemed most interesting to us, so we chose the case about autism. The next step was to formulate our Pico question, which Nicole will go into a little more detail about in a few minutes. But this is essentially creating a question that we want to answer that pertains to our case study, and then we would find the answer through our research. The next step was to collect our evidence. So we used several different databases, including Cochrane Library, PubMed, Speech by Eric Ebscohost, and ASHA. And through this, we sifted through all of the evidence to find what was most relevant to our case. And then we consulted Dr. Bonino and Mrs. Taylor for their help in deciding what was also most relevant to our case. So then we needed to appraise our evidence. With this, we used a number scale, which Kaylee will go into more detail about as well. But this helped us to decide which articles had the most strong evidence and which ones maybe had less strong evidence for us. And that brings us to our clinical decision, which we're presenting to you today. This is our representation of our little friend, Tommy Johnson. He's a 5-year-old boy with autism. He lives at home with his mom, dad, and his 2 older brothers, one of which also has autism. He recently moved to a new school system, and he was placed in a special education classroom with 6 other students, so there are 7 total students to 1 special education teacher. Some of the strategies as a background that they have tried with Tommy before have been ASL, which is American Sign Language. And with this, Tommy did fairly well with it. So he was able to imitate the signs really well, but he did not initiate conversation. His parents found this a little bit limiting as well because his peers who did not know sign language and his brothers did not know sign language either, so this limited his amount of communication partners. Something else they have tried is PECS, which is the Picture Exchange Communication System. And this is a communication system where the child is first taught the basis of a communication exchange by using a picture-based icon in exchange for a desired action or item. So they'll hand it to their communication partner, who will then fulfill that action immediately. After they learn how to do that, they will eventually move on to putting sentences together, as well as formulating questions and commenting on questions. Tommy is currently at phase 4 out of a total of 6 phases, and phase 4 indicates putting together simple sentences. He has done fairly well with PECS, and he has moved along very quickly, so his parents are happy with his progress so far. In a recent IEP meeting, 2 of the different approaches that were suggested were Lovaas Intensive Behavioral Treatment Protocol. And this was something that his parents were a little bit hesitant about because of the one-on-one nature of the treatment. Something else that was suggested by his special education teacher, though, was TEACH, which is Treatment Education of Autistic and Communication-Related Handicapped Children. And this is something that we will go into further detail in a few moments. But we do want to point out that Tommy's teacher has already put some of these strategies into place in his classroom. So she does structure the physical environment as well as use a daily schedule to regulate the students.
After choosing Tommy's case, we wanted to learn more about his diagnosis of autism so we could better get a picture of his characteristics. Autism is a neurodevelopmental disorder, which means that symptoms are found early in development. Children with autism also have difficulty with social interaction, and social communication skills. This means they may have difficulty with the back and forth of communication, meaning they may not know when it's time to make a comment in a conversation or when to initiate a conversation. They may also have difficulty with joint attention, which is the shared focus of an object with two communication partners. They may also have difficulty with nonverbal and verbal communication. These children may also have repetitive and restricted behaviors such as repetitive motor movement or repetitive use of objects. They will also have limited interests such as only really liking SpongeBob. These symptoms cause impairment in daily functioning across all contexts and communication partners. It's also very important to note that this is separate from an intellectual disability or global developmental delay. Even though, yes, some of these children may have intellectual disability, it is not part of this diagnosis. Autism within the DSM-5, which just came out a couple years ago, is diagnosed as a spectrum. This is different from the DSM-4, which diagnosed autism into certain groups, such as Asperger's. This term is no longer used in the DSM-5. Within the DSM-5, there are 3 different levels based on the level of support. A level 3 is a child that needs a lot of support within school and at home, maybe needing an aid with them in both contexts. This would be your typical child of low-functioning autism. A level 1 is your typical high-functioning child with autism, and they may need a low-level support, maybe just speech therapy in the school. So next, we created our Pico question. Pico stands for Population, Intervention, Comparison, and Outcome. With population, we are looking at the age and disorder of our client. The intervention is what treatment approach we think would work well with our client. And then we're going to compare that to another treatment approach. The outcome is what we would like to see in our client with whatever treatment approach we decide to choose. I will now present to you our Pico question so you can cross it off on your visual schedule. Our Pico question is, will the TEACH protocol help promote not verbal communication more effectively than low-VOS? Will the TEACH protocol help promote verbal communication more effectively than low-VOS intensive behavioral treatment protocol for early school-age children? So now I'm going to break that down for you. Our population is early school-age children with autism. Since Tommy is 5 years of age, he matches that early school-age group. The intervention that we chose is TEACH, since the teacher is already using this techniques in the classroom. We're going to compare that to low-VOS, since that was another treatment approach brought up in the meeting at the school. In the next slide, we will actually compare and contrast both of these treatment approaches. The outcome we would like to see in Tommy is an increase in his verbal communication.
Okay, so you've heard both of these terms, and I'm sure you're wondering what the difference between these two are. So we're going to break it down for you in this table we have here. This is like comparing our peas and carrots, as we had stated at the beginning, because they are very different approaches. One thing I do want to mention before moving on is that low-VOS here is used as an overarching umbrella term. Throughout our research, we came across other terms and different types of principles that stem from the low-VOS treatment, and these include DTT, Discrete Trial Training, ABA, Applied Behavior Analysis, as well as EIBI, Early Intensive Behavioral Intervention. So to begin, TEACH is a developmental approach, which means that you're looking at the level of development that the child has at that current time, and you're also looking at their strengths as well as their interests to base off of your approach. Low-VOS, on the other hand, is a behavioral approach, which means that you're looking at the behaviors that the child exhibits. So you're trying to increase the wanted behaviors and then decrease the unwanted behaviors. The ultimate goal of this would be to have the child blend in a little bit more with the peers around them. TEACH can be used across the lifespans for all ages, and on the other hand, low-VOS is typically used between the ages of 2 and 12, but it's recommended to begin using low-VOS between the ages of 2 and 8. Both treatment approaches do focus on language and social communication skills, but we do want to point out that low-VOS specifically focuses on decreasing those unwanted behaviors.
So both of these treatment methods have some parental involvement involved in them, but they differ a little bit. So TEACH, the parents are taught the treatment methods to use at home, but they also help create a treatment plan because they are the ones who know their child's needs the best. In low-VOS, the parents are the ones providing that one-on-one intensive therapy in the home to maximize their hours of therapy that they get each week, which Nicole will touch on in a few moments. Both of these treatment methods can be used in a wide variety of settings, which is great for generalization, so they can be used in the school and at home and any other activities that the children may be involved in. And both of these treatment methods can be used at an individual level, but we also want to point out that TEACH has the group aspect as well. So that kind of lessens the burden on professionals and the fact that they can have a greater student-to-teacher ratio.
For both of these approaches, there are different parameters for the amount of sessions and the amount of hours there is treatment. As you can see, LOVAS has more intensive treatment for the preschool age versus TEACH. For the older school age children, there was unspecific guidelines on the parameters on their website. So we are unsure about the amount of sessions and hours for these. So they're variable. Since these are very different approaches, one is developmental and one is behavioral, we expect to see very different techniques utilized in therapy. Since TEACH is a developmental approach, you will see them using structuring the physical environment to promote communication opportunities within the session. They also use visual supports, such as your visual schedule, to teach the predictability and structure of a routine in the classroom. Since LOVAS is a behavioral approach, they will focus on one behavior at a time in the therapy session, and the clinician will use reinforcement to increase the wanted behaviors and decrease the unwanted behaviors. For instance, if a clinician is working on getting the child to give the clinician eye contact, when the client gives her eye contact, she will give them the desired toy. When the client does not give her eye contact, the client will not get the desired toy. This will just, once again, improve the wanted behavior. And eventually, the clinician will decrease the prompting, so the client will eventually do this independently.
So now that we have defined our population and the two different treatment methods that we are going to examine, we had to look through all of the databases that Shelby had mentioned earlier to find evidence that was going to answer our clinical question. And when we did this, we came across many different types of articles. So what we had to do was determine which ones were going to be stronger in evidence than the others. To do this, we used this pyramid. So at the top, you see the strongest forms of evidence, which are your meta-analyses and your randomized control trials. And a meta-analysis is a study that looks at previously conducted studies that include randomized control trials. And they try to combine the results of those studies to come up with an overall conclusion about the question that they are asking. A randomized control study is a more experimental type study in which the researchers randomly place participants into groups and then manipulate variables to see what the outcome is for whatever the question that they have. The next level down is the controlled study without randomization and quasi-experimental studies, and these are very similar to randomized control studies, except they don't have that element of randomization. So the researchers either knowingly place participants into groups, or they are placed into groups based on convenience. The next level down is your non-experimental studies, so these are your correlational and case studies, and these studies follow groups or individuals across time to see how they change and progress. And at the very bottom, you have your lowest level of evidence, which is your expert committee report and your clinical experience. And these sorts of things can be found on ASHA's practice portal, so it's agreed upon best practice standards by experts. So, after we looked through and determined what each of our studies were, we had to individually examine each study, and we did that using this assessment criteria. It's based on a point system, so each study we examined to see if they had each of these elements. And if the study did have these elements, then they would get points for those elements that they had in their study. So the highest number of points that you could have got was a 7. So as close to 7 as the study was, the higher the evidence. So in this slide, you can see that through the search terms that we used, we came up with these 7 articles. We started with 12, but then we kind of narrowed it down to the ones that were most effective in answering our question and had the highest evidence base. We found one study that compared both TEACH and LOVAS. So this one is our gold standard study. And then 4 studies which looked only at TEACH and 2 studies which looked at only LOVAS. So you see to the left of the study names, the ratings which each of these studies received. So the 5s received points for things such as having a study design that was a meta-analysis or a randomized control trial, as well as other elements such as reporting their statistics such as precision and effect size, and adequately describing their participants. The 4s and 3s did not get points for the study design because they weren't randomized control trials or meta-analyses, but they got points for other things such as the precision and effect size that I had mentioned earlier, and in different combination with other elements. So they only had 4 of the elements that we were looking for, and these ones only had 3 of the elements that we were looking for. So they weren't as strong. In the next few slides, we're going to go over the results of each of these studies.
So you can now check off your magnifying glass in your schedule.
Okay, so in one of our first studies that we looked at, Reichow and colleagues conducted a meta-analysis of 5 different studies, and they were looking at EIBI, which is early intensive behavioral intervention, and compared it to the generic special education that the child with autism would typically receive in the school. And after they looked at both of these, it was after a 2-year span of time, they retested the children, and they found that those who received EIBI overall had improved expressive and receptive language skills, as well as daily communication skills and overall socialization skills. In another study by Ben Itzchek and Zukor in 2007, this was a non-randomized control trial, and this is where they had 25 total participants, and all the participants were diagnosed with autism either using the ADI, which is the Autism Diagnostic Interview, or the ADOS, which is the Autism Diagnostic Observation Scale. And they also wanted to leave out any comorbid conditions, so they just had autism. All of these 25 individuals received ABA therapy in a one-on-one setting for a minimum of 35 hours a week. They wanted to see how the pre-intervention conditions were affected by the outcome. So they did find that those who had a higher IQ and lower social deficits actually had the greatest gains in overall receptive and expressive language skills. One of the limitations for both of these studies was that the population used was less than 5 years old, and for Tommy we were specifically looking for 5 years and older, but these still have good outcomes for Lobos.
So Ospina and colleagues conducted a meta-analysis which looked at a variety of studies comparing different treatment methods for ASD. The researchers were looking at a change in the core features of autism, like Nicole had mentioned earlier, social communication, language, and they were also looking at non-core features of autism such as IQ. The researchers found that Teach and Lovas were equally effective in improving reciprocal social interaction and communication for children with autism. Boyd and colleagues created a quasi-experimental study in which they looked at Teach versus Leap, which is another type of developmental strategy, and a non-specific intervention, such as just general special education. And this was more convenience sample, so the participants were placed in groups based on the training that their SLP had already had in the past. They were looking at changes in the scores on about 8 different standardized assessments to see if Teach, Leap, or the non-experimental group would improve things such as communication and social interaction, and they found that Teach did improve communication and social interaction for these children. We want to note, though, that both of these studies had a mean age of at least 5 years, which is kind of right in the wheelhouse where we want to be for Tommy Johnson, because he's in that early school age population.
After we found that Teach would be effective for our client, we then decided to look into factors where Teach is most successful. Veros, Artigo, and colleagues did a meta-analysis that looked at many different studies that had Teach versus no treatment across the lifespan. They found that Teach was able to improve communication and social skills within all ages. However, it's important to note that adults had more gains in communication than children, even though there were still gains with children. Ichikawa created a randomized control study that looked at the difference between having children receive Teach and a social skills training versus moms going to 3 group sessions on non-specific topics across 6 months. They found that the Teach and social skills training had a better improvement of communication skills based on composite scores, and that Teach was more effective for children with higher IQs. And then they also gave the parents a parental stress index, and they found that Teach was more effective for parents with lower stress and parents that only had one sibling with a disability. Diella and colleagues created a non-randomized control study that looked at Teach versus an unspecific approach that had an aid in the classroom, psychomotor, PT, and speech. they had found that since the teach in this research study was low intensity, there was not significant difference between either one. So the researchers came to the conclusion that it was probably because of low intensity of teach and that teach should be used in high intensity. We will now share with you our clinical decision.
All right, so after examining the current best evidence, we also had to integrate that with the client and family values as well as our clinical experience to come up with the best decision for Tommy Johnson. So the current best evidence tells us that both Teach and Lovas have shown improvements in social communication as well as communication. And that is what we were looking for Tommy, so that was important to his family as well as the team that he is working with, that he improves his social communication skills as well as his communication skills within his environment. Both of these treatment methods, as we mentioned earlier, have this home program, and it has been shown to be successful with Teach especially for these children with autism, and that was important to his family as well because they were able to implement PECs so easily and successfully in their home as well. So we know that that's going to be an important factor for them. We also know from the research that Teach can be used across the lifespan, and this is important because Tommy's going to have autism for his entire life and he's always going to need these supports. So we wanted to pick something that is going to stick with him in the long term so that he can always have the supports that he needs to function in his life. We know also that Teach does not require an aide, which kind of lessens the burden on Tommy's school and doesn't, it won't force them to have to hire another person to work with Tommy one-on-one. His teacher can go ahead and implement the strategies once she receives her training. Finally, the research has shown us that using both Teach and Lovas was not recommended because they're so different theoretically. One is developmental, one is behavioral. By combining the two into a hybrid approach was not going to be effective for improving communication and social skills. So we know we have to pick at least one of these treatment methods.
One of the other big factors that we had to look at for Tommy was his own values as well as his family values overall. So we knew that his family really wanted to improve his socialization. This was very important to them. They wanted him to be able to interact with his peers, and they also really wanted him to be able to interact with his brothers. So this was something that they wanted to show in his improvements from whatever treatment approach that we chose. They wanted something that they were able to implement immediately in the home. They didn't want an extensive training program. They wanted something that they could easily implement just like PECs. And again, we want to emphasize that Teach was already started to use in the classroom, so this was something that Tommy's special education teacher reported that he had done fairly well with already, and so we want to build upon the client's strengths from there.
After looking at the current best evidence and our client and family values, we then looked into our own clinical experience as well as Dr. Benino's and Mrs. Taylor's experience as well. We were very interested in making sure that Tommy's team could participate in training with whatever treatment approach we chose, and Teach and Lovas both allowed us to do this. We then looked at Tommy's strengths. As Shelby had said much earlier in the presentation, that with Tommy's use of PECs, he was very good at being able to communicate with picture-based icons. We felt that Teach may be a great treatment for him since the use of the visual schedules can also use picture-based icons. As SLPs, we have a strong interest in improving his social communication and interaction skills. We feel like Teach can do this best because of the group and individual sessions. And we were afraid that with Lovas and having a one-on-one aide that he may not be able to communicate with his peers as effectively.
So this brings us to our final clinical decision that Teach would be the best option for Tommy, if you couldn't figure that out already. So we know that Teach is going to be effective in improving the outcomes that we were looking for Tommy, and that it's going to be useful for his family to implement in the home, and it's going to allow him to have greater success in generalizing to other environments because of the lack of the one-on-one nature, as Nicole had mentioned. So we feel that Teach is going to help Tommy soar and have the best outcomes that he could possibly have.
We are now on our last content slide.
So, after looking at all of this evidence about Teach, we are left with a few questions. One of the very first questions that we have deals with the parent program that is prescribed in Teach. because lots of the research articles, talked about this parent program, but none of them really specified the specific parameters that were going to make it successful for these children. So we want to know, the dosage that's necessary for the parents to provide this therapy in the home, what sorts of materials they're going to need to use, and what the therapy is going to look like with these parents. And we want to know that so that we know the most successful combination of those things for these children. The next question that we have is regarding teach in combination with other strategies, because we know that teach in combination with a behavioral strategy such as LOVAS was not successful in the past. So we were wondering if another developmental strategy in combination with teach would be able to fill any holes that teach has for children with autism. We thought perhaps something later down the road, like job-specific training, would be able to be combined with teach, or any other developmental strategy that is available. Finally, many of us know from working with Dr. Benino in her 1804 and Autism Speaks lab that creating materials for a program such as TEACH is very time-consuming and requires a lot of materials. And a lot of parents and SLPs do not have the time to do this. So we were kind of wondering if there were any alternative delivery options, such as telepractice, or something to that effect, so that people in any situation can receive this treatment and have success in their life.
And with that, we would like to thank you all for listening, and especially Dr. Benio and Mrs. Taylor for all of their help in this EVP process.
Any questions?
Oh, two questions. You can go first.
Okay. Thank you for the presentation and the comparison with TEACH and LOVAS. I'm personally happy that you picked the TEACH program. I have some experience working within that program, and I was wondering if you had given consideration at all to whether the child would be in more of like a self-contained classroom where it would be with other children that may be diagnosed with ASD, or is this a child that is going to be more appropriate for sort of a mainstream kind of situation where the child may be moving around either to different or to a classroom where there are children with ASD, and how that might impact the implementation of TEACH?
Right. So Tommy, we didn't really get a severity rating from his case history, but we know that he doesn't have a lot of problem behaviors. He just, his main thing is he doesn't have a lot of verbal communication at this point since he has to use the PECs. So it's possible that he could be moved around in other classrooms, I would say, not just a self-contained classroom. But it would only, I think the main way that it would affect the implementation is that other teachers and faculty that he would be in contact with would also have to receive this TEACH training. But that would, I think, really be the only obstacle to doing this. And, it's not, I don't think that it's, too far reaching for them to do that.
Yeah, and that's why we chose TEACH, is because it allowed other people to be trained in it so he could use it throughout his life.
I think the ultimate goal for his parents, just from learning about them in the case study, would be that to mainstream him. So like maybe have him in a classroom down the road. So then they would have to discuss that in the IEP meeting, like who the teacher would be and like who is going to receive the training. Because the SLPs and other people providing services will already have the training, but maybe they'll have to add more people and do another one.
Also enjoyed the presentation. I just wondered, I understand what you're saying in terms of overall approach, and that you shouldn't try to do two different approaches at the same time. I just wondered if you ever thought there was room for some behavioral elements in a pretty self-contained skill, like tying your shoes, or something that really lends itself to a task analysis, so that to say, well, we're never going to use behavioral techniques. Are there certain times that you might?
Right. Obviously, PECS is very behavioral in nature, so there's definitely room to use behavioral, treatment, but not, I don't think, full scale. I think that the article that we found saying that they don't mesh well was using like full scale, both of them at the same time. But yeah, there's definitely instances where a behavioral kind of task could be implemented with these strategies. I don't think that they are so, separated that they can't coexist. Obviously, with the use of text and the use of these visual schedules, I don't think that would be too much of a stretch. Okay.